Hematology, oncology, pharmacology, other anticoagulations. All right, so for this next video, I'm just going to be talking about all other drugs that aren't heparin and warfarin that we're going to be seeing in hematology, because anticoagulation is kind of a huge thing. It encompasses a lot of different medications, as well as antiplatelets, thrombolytics, anticoagulation reversals, and direct coagulation factor inhibitors. So we're going to talk about each of those separately, but we're going to just put it all into one big video. This isn't as high yield as heparin and warfarin, hence that's why we have the videos for the other ones separately. All right, so to begin off, we have the direct coagulation factor inhibitors. The reason we like to use this more often now and clinically, okay? So, I mean, they're not gonna be asking this on boards, but there's no requirement for lab monitoring. So I don't have to worry about PT or PTT, right? Because these they don't require lab monitoring. So it's a little bit more helpful. You don't have to bring the patient in and monitor their PTINR or their PTT. So that's the first thing. Now, off rip, what we need to understand, I'm going to be providing a bunch of drug names that I'm horrible at pronouncing. So, I mean, just bear with me here. All right. So the first one is bivalirudin, argatroban, and dabigatran. Okay. So those are the first ones. Now, once again, these aren't that high yield, but you have to understand that they directly inhibit thrombin. Okay, so they directly go and inhibit thrombin, whereas heparin, what it does is that it activates antithrombin, which then goes and inhibits thrombin, okay? These ones, they directly attack thrombin factor 2, okay? And these are used in HIT, okay? So that's one of the things that they love to ask about, okay? Obviously, adverse effects for any blood thinner is going to be bleeding, and you can reverse these with idarucizumab, okay? Very long word, they don't really ask much about it. Next is apixaban, edoxaban, and rivaroxaban. This is a direct inhibitor of 10A, factor 10A. And they've put it in the name. If it ends in exaban, then you know you're dealing with a 10A inhibitor, okay? Now, they like to use this mainly for stroke prophylaxis in patients with AFib, okay? And you're going to provide it via oral agent, okay? So it's very easy to be taken because it's taken orally, and it's used for stroke prophylaxis, usually with patients that have atrial fibrillation. Now, next is antiplatelets. Okay, so let's discuss antiplatelets a little more in depth because this is very, very high yield for your understanding. Okay, so the first thing that we can do is that we can provide a patient with aspirin. Okay, now what does aspirin do? Aspirin irreversibly blocks COX. Okay, and that leads to a decrease in TXA2 release, which leads to a whole decrease in just aggregation and activation, okay, of our platelets. Now, they love to ask about the irreversible aspect of it, okay? And the reason behind it is that it's very important to know if someone comes in for surgery or someone comes in for a high risk of bleeding, you have to tell them to stop the aspirin 7 days out or a couple days out, a couple weeks out before they start that surgery, because you need to completely clear your aspirin out of your body because it irreversibly blocks COX. So you have to wait for reproduction of new molecules in order for aspirin to be completely gone out of your system and for you to be okay with aggregation, okay? So this stops platelet aggregation by irreversibly blocking COX, leading to a decrease in TXA2, okay? Very important to know. That's the first thing. Next thing, clopidogrel. Okay, so clopidogrel, also ticagrelor and others, okay? But clopidogrel is like one of the most important ones. This blocks your P2Y12 receptor, okay? And that's where ADP binds, okay? And since we're blocking ADP, binding to its receptor, then we have a decrease in expression of GP2B3A, right? Because we discussed earlier on that ADP is released in response to GP1B binding via platelets and von Willebrand factor. And then ADP goes and it binds P2Y12 in order to release the GP2B3A receptor. So if we don't have that initial binding of ADP with its P2Y12 receptor, then our GP2B3A expression will no longer be increased, okay? So what they like to say, if you have a patient that comes in, they need anticoagulation therapy to decrease platelet aggregation, they love to give both clopidogrel and aspirin. It's usually used as a dual therapy. Next, okay, this is the fibs, okay, so eptifibatide and tirofiban, okay? This blocks GP2B3A. So the difference between clopidogrel and these drugs is that clopidogrel blocks ADP, which induces the expression of GP2B3A. These directly block GP2B3A, okay? And that, once again, is going to have the same effect, okay? But what they like you to know about this one is that there's an adverse effect of causing thrombocytopenia, okay? So be aware, look for your platelet levels, see if thrombocytopenia has been, if it's being caused, if your platelet levels drop. Lastly is cilostazol and dipyrimidol, okay? These are phosphodiesterase inhibitors, so they block phosphodiesterase, which automatically, anytime that you're blocking phosphodiesterase, you're going to lead to an increase in CAMP and platelets. Increase in CAMP and platelets causes an abnormality with platelet aggregation, and so this is why we use it. They love to ask this, but the main reason we can give cilostazol and dipyridamole is for peripheral artery claudication, okay? So peripheral artery disease. So if you have claudication, intermittent claudication, they can provide you with cilostazol, okay, which blocks the PDE, right? So phosphodiesterase, leading to increased CAMP, and that's when they mainly use it, okay, for claudication purposes to help treat claudication. And lastly, thrombolytics. Thrombolytics is your TPA, right? So anytime you're going to see like the medications have like TEPL-ACE in it, okay? So to place sounds like TPA, and that's how you know you're dealing with a thrombolytic. And we know what TPA originally does, right? TPA activates plasmin from plasminogen, okay, in order to dissolve any clots in our body, okay? We rarely ever use it now clinically due to the fact that it has such an increased risk of bleeding, so you have to be worried about it. That's why we usually go in for percutaneous intervention, PCI. But if PCI is not available, we can give the patient TPA, or it could be used as a direct thrombolytic, thrombolysis of high-risk PEs, okay? Very low yield, usually put heparin as the answer, but keep in mind that thrombolytics can be used. But the reason we don't, once again, is because of that adverse effect of bleeding. Severely contraindicated with anyone that has active bleed. If you have a patient that's coming in with like a bleed or a stroke, right? Non-ischemic stroke, you have to worry about this because you can't give them TPA. They have an increased risk of bleeding. Now, how do we reverse it? We can give them tranexamic acid or aminocaproic acid. These reverse our TPA effects, okay? That's all we really need to know. I would say the most important and highest yield would probably be our antiplatelets, besides our heparin and warfarin usage. But this finishes our hematology portion of pharmacology, and we're going to be entering our oncology portion for pharmacology.